Good evening. My name is Heather, and I will be your conference operator today. At this time, I would like to welcome everyone to the Myeloma Updates 2013 Post-ASCO EHA conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star followed by the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Ms. Susie Novis, President of IMF, you may begin your conference.
Thank you. Good evening, and welcome to the IMF Post-ASCO and EHA teleconference. These are two very important meetings that take place each spring, and it's the time when doctors and researchers present their most recent data. So tonight you'll be hearing the highlights from both of those meetings. Our speaker is Dr. Brian Durie, and I have to say I happen to know him quite well. Dr. Durie, for those of you who don't know him, is the chairman of the board of the IMF, and he's also the chair of the International Myeloma Working Group. I know that Dr. Durie has a lot of very interesting information to share with you. And of course, we'll take as many questions as possible at the end. But I know that some of you may not get your question answered, so I want to remind you that our hotline is available to answer any of your questions. In the summer, they're available Monday through Thursday, 9 a.m. to 4 p.m. Pacific time, and on Friday, 9 a.m. to 3 p.m. So now it's my pleasure to turn the call over to Dr. Durie. But before I do that, I just want to thank our sponsors, Celgene and Millennium, for making this teleconference possible. Brian?
Well, thank you, Susie. I'm very pleased to have this chance to update everyone. As I've indicated on my cover slide, this is the summer update. This is the middle of the year update to kind of track where are we with new information in this middle part of the year. And as Susie mentioned, there are two meetings that occur. The first one is the ASCO meeting, and on the front slide you'll see that is a picture of downtown Chicago, which is where the ASCO meeting was held this year. And then to the right you'll see a picture of downtown Stockholm, which is where the EHA meeting was held, and also the working group summit. And so I'm going to touch upon a very important series of outcomes that came from those three meetings. And I have a subtitle for today, which is The Impact of Innovation. And this is the overriding theme of this presentation, which is to kind of show what is the impact of these new observations, these new drugs which are showing promise in trials, and how are they moving the field forward? And in this case, to be very specific, we're interested in how many more patients are achieving remission, how much longer benefit are we seeing with these remissions, and how are we seeing the impact in terms of survival. And so if we go to my next slide, which is called Impact of Innovation, and identifies penicillin as an interesting example way back early in 1942 to show what happens with a new agent. What happens when you come up with something which is truly new? And it's helpful to look at, after it was discovered that penicillin killed a bacteria in the Petri dish in the lab, it took 13 and a half years to make enough penicillin to treat one patient. The first U.S. civilian patient, a woman, was ultimately treated 13 and a half years later in 1942. She was cured of her pneumonia and lived almost 60 more years. And so you can see that if you really have successful treatment, that impact can be truly incredible. But I wanted to point out two or three other things here. The cost of that penicillin when she was taking it was actually $1,000 a day. Massively expensive when you're working to come up with something new. But over a period of 7 years, the price had dropped dramatically. And so this is kind of what we see through the patent process these days, where during the initial years there is a drug recovery cost, but ultimately the cost does drop significantly. What I want to emphasize tonight is that 13-and-a-half-year time frame is a long time, but we are very fortunate right now in the area of myeloma because we have a number of drugs that I'm going to talk about tonight, and these drugs have already gone through that 13 and a half years, and they are to the point where they're going through the initial patient treatment phase. And so we are to that point where we can see that added benefit. If you go to the next slide, which is called myeloma survival in 2013, you can see what has been the sequence of improvement since we first started having treatment which worked back in the 60s, that being melphalan and prednisone MP. And you can see that we had further improvement in the 1980s and 90s, but really the 13-year time frame, interesting, the 13 years between the year 2000 and 2013, we have seen the impact of the novel agents. And so if you go to the next slide, it's a slide which some of you may remember having seen before. I used it from the updates at ASH where this was first presented. But I think it's important to come back to it and show that with the impact of the novel therapies, there has been a really significant improvement in overall survival, with the median overall survival currently being 7.5 years, and it's almost certainly higher than that now because that was up until 2010. And it's important to remember that this is a doubling of survival since back in the year 2000. If you look at this slide and you look at the impact of age, what I want to emphasize is that initially we were seeing improvement in survival for patients under the age of 65. But what was especially encouraging in this recent update was that patients over the age of 65, patients who were not receiving a stem cell transplant, were starting to see the impact of the novel agents, thalidomide, Revlimid, and Velcade, with an improvement of the 5-year survival to over 50%, 56%. And so we really are starting to see a strong impact on responses, remission duration, and survival. And so this brings us forward to really where are we now in thinking about the approach to treatment. And during this year, there has been a renewed focus on 3 aspects. And I'm going to be touching on all of these tonight. The first one, which has been a particular focus of attention, is which patients to treat. And the question has been, should we be treating patients with smoldering myeloma before they have developed what we call CRAB criteria, calcium elevation, renal or kidney problems, anemia, or bone problems? We do definitely treat patients who have these kind of issues. The second thing, which I'll also be emphasizing and discussing, is that should our focus of therapy be to just control the myeloma, or should we finally be looking in a more definitive way about trying to cure some patients with myeloma? And the answer to that question is really good news, because I think it's clear that we can be focused on this finally. And then the third point is which combinations are really the most promising, and should we be using just one drug or possibly 2 or 3 drugs, or more complex combinations of the 3 different types of drugs, the IMID type, the proteasome type, and the alkylators. And so what are those key combinations and regimens that are being discussed and which many of you are taking right now? Well, the commonest 2 drug regimens that we're using are either Revlimid and Dex or Velcade and Dex, and many of you, I'm sure, have taken those or may be taking them right now. A key question right now is, are 3 drugs better than 2 drugs? And a number of trials are going on to test that. Some of the main 3 drug regimens are the Velcade combinations with Cytoxan. The acronym for that is the CyBorD, Cytoxan, Bortezomib, and Dex, or Velcade Revlimid Dex, Velcade Thalidomide Dex, or if you move down into the 4 drug regimens, if you would add in extra drugs to have that 4 drug combination. I think the summary right now is that 3 drugs are broadly applicable to get the best response, and particularly in younger patients who are headed towards stem cell transplant. In older patients, a 2-drug regimen might be perfectly adequate, and particularly with lesser side effects and better tolerance. So what are the newer treatments that have been the focus of the attention this year, and where are we? Do we have any new updates on those drugs? As you are probably aware, the newest treatments for patients who've exhausted all other therapies, this is the slide that I'm on, are Carfilzomib, otherwise known as Kyprolis. This is the next generation proteasome inhibitor after Velcade. The key points about this are it is an IV drug. It causes much less neuropathy, very little neuropathy, and it was approved in the middle of last year. The pomalidomide, which is the most recent generation of the IMiDs after thalidomide and Revlimid, is obviously by mouth, a capsule, and it was approved just earlier this year. And the good news is that it got a positive opinion in Europe in June, with a likelihood of approval in Europe later this year. And so we're always looking, the IMF certainly is very concerned about access to all of these drugs, both in the U.S. and outside of the U.S. And so what updates did we get related to these drugs or other topics at ASCO this year in Chicago? And so I have a couple of slides that just identify some of the top abstracts that were presented at ASCO this year in Chicago. First of all, you'll see I have identified a couple of abstracts from the Italian group in Torino, Italy. Both Dr. Palumbo, who was the lead author, and Dr. Mario Boccadoro were at ASCO this year and presented or were present for these abstracts. The first one, Revlimid maintenance, was very interesting because this one, abstract 8509, looked at Revlimid maintenance after melphalan, prednisone, Revlimid, or high-dose melphalan. And the interest in this was that it is another study where there is overall survival benefit for patients who stay on the Revlimid maintenance. And so a lot of people were interested and anxious to see the result of that, to see if it really did improve survival, which is certainly what we're looking for. The second one from the group is a linked aspect to that. If you're taking Revlimid, what is the increased likelihood of second primary malignancies? And so Antonio Palumbo collected over 6,000 data reports from patients in different studies and analyzed to see which factors were linked to the likelihood of getting a second cancer, things like a breast cancer or prostate or colon cancer, something like that. And the numbers are small percentages, 3%, 5% or less. The higher percentages, it turned out, were more linked to patients being exposed to melphalan in some of these regimens. There was some increased risk with the use of Revlimid, but this was actually a little bit lower. And the overall assessment is that certainly the use of Revlimid in maintenance doesn't produce a sufficiently increased risk of second primary malignancies that would negate the significant doubling of remissions and improved survival that we're seeing in some of these studies. The pomalidomide, a number of different abstracts on pomalidomide that I'm going to highlight in a little bit more detail in just a second. Some small points which are important. One abstract showed that you do not need to adjust the dose of pomalidomide downward if you have some impairment of kidney function. A number of studies continue to show the value of different pomalidomide combinations in relapsed patients, really supporting the fact that this is a very, very important and promising new drug. I'm now moving to my second slide on ASCO highlights. The top of this slide is Carfilzomib. There were several abstracts on Carfilzomib. The 2 points that I want to emphasize, this is not really new information, but this is the way that information goes, and this is an important point to be aware of, is that the information increases in little steps, and so that in one study we have updated results of using Carfilzomib, Revlimid, and 1 day a week Dex, the little d, and it continued to show excellent results in patients with frontline disease. and a very high incidence or occurrence of stringent complete response. And this is a study from Dr. Jakubowiak, who is now in Chicago, actually, and these results have been previously published in Blood, but the way things go is that there are constant updates that get presented at these meetings like ASCO. Another study was presented, which is carfilzomib combined with melphalan and prednisone, CMP. This is another excellent combo that was presented from the IFM group in France, and this has been presented before, and this is similar to the Velcade or the VMP regimen that many of you are probably familiar with. The carfilzomib is good, maybe better, and does not cause neuropathy, so quite a bit of interest in that. And then I'm going to touch on the three other drugs that I have listed there, giving a little bit more detail. The oral proteasome inhibitor for Millennium, MLN9708, Elotuzumab, a very exciting new monoclonal antibody, and then the anti-CD38 monoclonal antibody, a lot of interest in that. So if we go forward to the next slide and just kind of look at the whole range of novel agents, and not all of these were discussed at the ASCO meeting or at the EHA meeting, but just to kind of look at them in a framework of first generation and then next generation. The way that treatment has moved forward in myeloma has really been in two ways. If you look at the two columns, you can see first generation lenalidomide, bortezomib, and then you see the next generation, you've got pomalidomide, and then several second or next generation proteasome inhibitors. And so this has been so important to have two categories of drugs which work so well in myeloma. And this is why we're seeing the benefits of innovation, that these two classes of drugs are working well, and the newer chemical variants of those have different advantages of sometimes working better or having lesser side effects. But then if you track down through the column with first generation, what is very exciting is that we have several new types of drugs in that column, and I'm going to show you some of the most promising results of those drugs which are listed there. If we go to the next slide, the first thing I want to show you is just the updated results for pomalidomide that were presented at ASCO. Dr. San Miguel from Spain presented the update. They had been presented at ASH and elsewhere. I would just draw attention on this slide to the results with pomalidomide plus the 1 day a week dexamethasone. 302 patients in this trial received that combination, and you can see 95 of those, or about a third of the patients, had an overall response rate, which means that they had a 50% reduction in myeloma protein levels or better. And you can see some of them had very good PR, which means a 90% reduction, so a significant improvement. And you can see that a very high percentage, 82%, had at least stabilization of their disease. If you look at the other column, you'll see that only 15 out of 153 patients had a response with the high-dose dexamethasone. And so the important thing is here that there are many, many more patients who are benefiting with the pomalidomide and the low-dose dex, which is impacting the outcomes. Next slide. So where are we with the new proteasome inhibitors? And data were presented on the two oral ones that I mentioned, the Marizomib. I don't know where they come up with these names, Marizomib, and then Ixazomib, which I find especially difficult. This is the one from Millennium. And I'm going to move quickly. If you go to the next slide, I'll show you the results that we have seen that were presented and updated at ASCO using the Millennium 9708, the Ixazomib, which is used in combination with lenalidomide, that's Revlimid and dexamethasone, the RID protocol in ND newly diagnosed MM patients. And this just shows you that the Millennium drug is given weekly along with the dexamethasone and with the normal cycling of the Revlimid, which is the 21-day cycle. And so if you look at the outcome of that in the frontline setting, if you go to the next slide, you can see that the results with this have really been very, very good. And you're going to see a number of plots which look like this next plot, which shows the best percentage change in the M protein level from baseline. These charts are called waterfall plots. And basically, it shows you the falling of the M protein levels. And you can see that the percentage of the fall or the dropping of the protein is illustrated on the left. So you can see that 100% is those blue lines off to the right. You can see that many patients were having 100% improvement with this combination up front. Very, very good. But you can see virtually all the patients are having some response, and a majority are having more than 50%, with many having that 100% reduction. Really, really excellent results in this waterfall plot. So people are encouraged to be moving this new proteasome inhibitor forward. And you can see also the progression-free survival. You can see that these frontline patients are doing very, very well out to close to 2 years. And so this is one of the reproducible benefits of these novel combinations now, is that we can have a new patient coming into the office, and we really can say without contradiction that chances are we can have patients responding and doing very, very well for these first 2 years, and in many cases for many years longer than that. And so progression-free survival, you can see here, 93% all the way out there, so doing very, very well. Next slide. The other drug similar to this in terms of the stage of development is Elotuzumab, which is a monoclonal antibody which has a direct effect against myeloma, but mostly is interacting with the microenvironment around the myeloma and is enhancing the effect of lenalidomide. And so this is a study where the Elotuzumab is combined with lenalidomide and once-a-week Dex. I would emphasize that this is a much smaller study, and in this study that was presented by Sagar Lonial, and also some data has been presented by Dr. Paul Richardson, you'll see that 2 doses of this drug, Elotuzumab, were studied. 10 milligrams per kilogram. This is given intravenously, important to be aware. This is an IV drug that is given along with the Revlimid and Dex. You can see 36 patients received the 10 milligram dose, 37 patients in the yellow received the 20 milligram dose. And the question was, what would be the outcome of that? If you go to the next slide, we have more of these waterfall plots. And I think it really helps you to see the different impact of these 2 doses. And the interesting thing here is, if you look at the left, you'll see that there are lots of green bars showing that there were more deep responses with the 10 milligram dose versus the yellow bars on the right with the 20 milligram dose, where there was a lesser number of deep responses with the 20 milligrams. And so this is kind of interesting and unexpected, where it seems like this is a situation where there may be an ideal dose, and giving more could even be counterproductive and maybe saturate the antibody response. People are kind of struggling to understand that and to explain it. If you go to the next slide, you'll see what happens in this case with the progression-free survival. The remissions are achieved and patients are staying in remission. And the very, very important thing here is, if you track over the green line, the 10 milligram dose, it goes over to the right edge of the chart. And this was updated actually at the EHA meeting by Paul Richardson, who showed that the median PFS, the progression-free survival, is 33 months with this combination. So this is a really excellent average length of remission with this 10 milligram combination. But people are still looking at the 20 milligram dose because this is a small trial, and so I think we're going to see more information related to the dose. But for now, at least, the 10 milligram dose, I think, is going to be the one moving forward. The next slide summarizes another exciting monoclonal antibody, anti-CD38. And again, this is an update from ASH that was represented actually both at ASCO and at EHA. It was presented at EHA by Dr. Lockhorst. This is an antibody where the dose is also being checked, and you can see with the dose escalation from the very, very tiny doses up to larger doses. One reason for that is that this particular monoclonal antibody can trigger allergic reactions, and some of those can be severe, and so there was a concern to be sure about the severity of the allergic reactions to the monoclonal antibodies. And some of you may have noticed that this is one of 3 anti-CD38 monoclonal antibodies that are available. There are 2 which are already in trials in the U.S. One in the U.S. is coming from a company called Sanofi, and some of you may have noticed that the Celgene Corporation recently bought the rights to another new anti-CD38 antibody called MOR202, which will be coming into clinical trials also. The fact that there are 3 separate companies looking at 3 different anti-CD38 antibodies gives you an idea that maybe they think this is important. And I think that the results do justify that. So they've moved from the dose escalation. If you go to the next slide, you'll see another one of these kind of, which I think is very nice, waterfall plots. In this case, with the different colors, you can see with the very, very low doses on the left, they did not see any drop in the M component. As you move to the right with the darker colors, you can see that consistently they were seeing responses. The important thing here is that this is just with the antibody. This is not some combination with Revlimid or the like. This is the antibody itself that is producing this response. Off to the right, you'll see that one patient had complete clearing of the free light level, and another one had a complete clearing of the serum M component level with intermediate and higher doses of this antibody. So very, very encouraging that this is occurring. And so I think that we are going to be looking at how these new antibodies combine with the new agents, the Carfilzomib and Pomalidomide, but also the older, what we call now the older drugs, which includes the Velcade, which is a very important drug, Revlimid, and also thalidomide, which we don't also frequently talk about, but is still a very, very important drug to be considered as part of the treatment paradigm. So if you go to the next slide, the last thing I want to discuss and update people on is the IMWG Summit. So this is the International Myeloma Working Group Summit. This is a collection of myeloma experts who meet immediately before the EHA meeting every year. This year, the EHA meeting was in Stockholm, so we met in Stockholm because that's where most of the doctors are going for the meeting. Reduces cost and is much, much more efficient for the group to meet. And so these myeloma experts, we have a collection of between 70 or 80 who come for this summit part of the workshop. And so what I'm showing on this slide here is things which were a focus for discussion on this year's agenda. We have a full agenda for the summit where we talk about updates in many areas of guidelines and research. But this year, there were 2 aspects which were new. One was that we were talking about tests to be used for the evaluation of minimal residual disease. So how do we test to see if there are little bits of myeloma left in the blood or the urine or in the bone marrow if the regular protein testing has become negative? And this was a very, very important topic for discussion. And then, as I was implying earlier, there was a lot of discussion about not just comparing one treatment versus another, but how to enhance the treatment to start to be curing patients with myeloma. And this turns out to be the Black Swan Research Initiative. And so it turns out that there was not a planned, but a complete synergy, as it turned out, between what was a focus of attention of our myeloma, 70 to 80 myeloma experts, and the focus of the Black Swan Research Initiative at this particular summit. So if you go to the next slide, the question opened up a little bit to evaluate, well, what is needed to achieve a cure? And so for MRD testing, we need better testing for the minimal residual disease, and I'm going to talk about that a little bit. The second point was, if we want to cure patients, what are the couple of things that we need to accomplish that? The first is, certainly in an important subgroup of patients, we should focus on treating early, and then we will have the best chance to really eradicate the disease, particularly in patients with good risk disease. But we clearly need to have new drugs, possibly some of the ones which I just was talking about a moment ago. If you go to the next slide, I want to illustrate that a number of the IMWG members, some of those who are working specifically on the Black Swan Research Initiative, are already working to try to move things forward to accomplish the goals of the Black Swan Research Initiative. And this particular summary from Dr. Vincent Rajkumar is defining CRAB, or early active myeloma. So if we are going to treat myeloma in a secure fashion before CRAB features have developed or we have symptoms of myeloma, we need to be sure that we're treating patients who really are going to benefit from that treatment. And so Dr. Rajkumar and his colleagues there, the Dr. Merlini and San Miguel from Spain, were talking about, well, how are we going to do that? If you go to the next slide, another investigator, Dr. Ola Langren from the NCI in Washington, is also speaking out on this topic and also working as part of the Black Swan Research Initiative. He is very much involved both on the side of looking at more sensitive MRD testing using cytometry and flow, and also molecular DNA testing. And he has, as a number of patients on the line may have heard or may even have gone to take advantage of it, he has a protocol for the treatment of high-risk smoldering patients using carfilzomib, Revlimid, and Dex. So he is clearly working right at the cutting edge of this new Black Swan Research Initiative. And he has a very nice summary in Blood where he outlines some of the details of how he's pursuing the curative blueprint for early myeloma therapy. If we go to the next slide, I want to just take you through a little bit of the discussions that occurred at the IMWG Summit in Stockholm. And I have to say it was a bit of a surprise to me that all of the investigators were willing and interested to focus as much time on this particular question. And what these investigators were focused on is the definitions and the categorization of the three types of monoclonal gammopathies. Obviously, we have the MGUS patients with very, very low level disease at a low risk of developing myeloma in the near future, the smoldering patients, some of whom may develop myeloma rather soon, and then obviously patients with myeloma who do have CRAB features. And so the key question was, which of the smoldering patients who do not have CRAB features need to be selected for therapy? If you go to the next slide, this summarizes how this can be considered because it shows you the rate of the progression to symptomatic myeloma. And on this particular chart, you'll see that there are two curves. The top one is smoldering myeloma, and the bottom one is MGUS, or monoclonal gammopathy of undetermined significance. Now, you can see that bottom one, it goes all the way out to 25 years. You'll see at the bottom. And you can see after 25 years, about 25% of the patients have developed myeloma. That means 1% per year. And so you can see we really don't want to be treating those patients. There's only a 1% chance that any one of them is going to get myeloma in a given year. If you look at the other chart, though, you'll see that it has a different curve. You'll see the first part of the curve is fairly sharp, where after the first year or two, 30% in that red box, 30% have actually developed myeloma. And so this is the target group. This is the target group of patients who have early active myeloma before they've developed calcium elevation, before they have renal problems, before they have anemia, before they have bone lesions, which is before they have CRAB features. And so if you go to the next slide, this shows how do you break down smoldering myeloma using this idea. And you can see here that we break smoldering myeloma into three groups now. We leave the MGUS patients alone. We redefine early active myeloma for that first group who get myeloma rather soon, but we also set aside the other two groups of patients, patients who fall in that middle group. Maybe it could be good to consider some more preventative type trial. For the patients with the third group, they really are just like MGUS. You can see the lines are almost parallel there, and they should just be followed without treatment. Next slide. And so this creates something that was an outcome from our summit meeting, which was, okay, where are we now then? Well, we have redefined MGUS. We've moved some patients from the smoldering group into the MGUS category. We're left with group number 2, the middle group, who should probably be evaluated for prevention. But then we take group number 1, which is that early group, the red box, and we move them over into the myeloma group and see if we can do a good job by treating those patients early. And so this is a very, very important outcome from our summit meeting. And so the next question you can see on the next slide is, well, how do we identify patients who are in that red box? And the answer to that is, right now at least, is that they're more likely to have a high level of plasma cells in the bone marrow, a free light level of over 100, and a lot of discussion focused on the idea of using PET-CT scanning to try to identify those patients where they could have a positive PET scan with even a little bit of early bone damage on a CT scan. And so now there is going to be an ongoing effort to validate that and possibly come up with some new and even better tests that will securely identify these patients. And this is part also of this Black Swan research initiative. But the key thing related to the Black Swan was using MRD, minimal residual disease testing, as a key tool to develop therapy to cure myeloma. And the outcome was that we needed to have a definition. And so if there's no minimal residual disease, if there is MRD-0, what does that look like? How do we identify that? So beyond what we have called complete response right now, the things that were recommended actually by the team of investigators was that we would use flow cytometry, where we would take the bone marrow and run it using an immune detection system through a flow cytometer to identify any remaining myeloma. And if this test turned out to be negative, that would be flow negative. We would then take the bone marrow and or the blood sample and see if there's any DNA specific to the myeloma, and then if that was negative, that would be 0 at the DNA level. This is a particular type of testing where you look at the sequence, the variable sequence of myeloma, so you're looking specifically at the DNA that is coming from the myeloma. To do this test, you need to have a sample of the baseline to see what is the DNA of the myeloma, and then see if that exact DNA is left or not. And then, as I was just discussing, having a negative PET or CT scan would indicate no active disease. And so, how does this all fit in to the key goal of the Black Swan Research Initiative? Well, using this testing, we can see how the treatment is progressing. And so the definitive therapy that we have right now can reduce myeloma to a low level, but perhaps not to 0. And so the whole purpose is to have a test that can tell us that, and also can tell us if we are moving towards MRD-0. And so we have a framework to test new agents, new combinations, to see if we can move from a low level of minimal residual disease to zero minimal residual disease. And obviously, this is what we are focused on. Now, although we identify here in this slide, and I've been talking about it, patients with early myeloma are the prime candidates for this, but actually, these new drugs that we're looking at have been working in patients even with much more advanced disease. So although statistically we would say, oh, well, we can do a better job up front, actually, it could well be that whatever curative approach is developed could apply across the board, and we're certainly hoping for that. And so in conclusion, I just want to give a little bit of overview perspective of the future of this Black Swan research initiative. You can see here in the second to last slide a black swan. And what does this black swan have on her back? This is a mother who has two little baby black swans who turn out to be white. And so this is certainly what we're hoping with the Black Swan Research Initiative, that we will spawn and have multiple projects that will help the whole field to move forward and come up with testing and protocols and new drug combinations that will find a cure very, very soon. And this would be for all patients with myeloma. And if you go to the last slide, many of you have seen this slide. It has the balance of the rocks. And in every case, as we're moving forward, we have to balance so many things. We need to have treatment that works. We have to have treatment that's tolerable. We need to have treatment which is ultimately cost-effective. You'll see on this slide of the rocks that the black swan has moved from the dark rocks on the right over to the light rocks on the left. So the black swan is moving into the light as we try to give more details about how we're trying to move this forward. You'll also see that the black swan is a little bit larger than he has been in other presentations. So we are trying to indicate to you that this is moving forward, that we have more information to share, and that we're certainly very, very optimistic about this for the future. So thank you for your attention. We are going to have some fast questions from the operator, and then we'll open up to